Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great and happy Sunday to everybody. All right, today, as I mentioned, that we are going to start one of the very commonly tested topic in licensing exam, whether you're doing NACOSKI or MCCQ1, it is going to be very commonly tested. So it's going to be in the licensing exam. I will point out the points that might be in the MCCQ one, and also I would definitely point out the points which are essential to be followed and applied in NACOSKI. All right. So basically, what examiner are scoring you? So efficient logical sequence that supports the patient's problem definition, sensitivity to problem, to comfort, modesty, and pain while examining. I will explain every single one of them. Targeted physical finding, functions, gait, neurology, and a special test only when indicated. So when you are doing a physical examination on someone, you need to start in a very structured way so that it doesn't give the examiner a hard time to score you. Okay, so if you're structured, it gives the structure, the examiner enough time, or it's not going to give the examiner a hard time to score you. But why? Because the examiner has the list of the things that you need to do it in an orderly fashion. And also, one of the most important things that we need to know is that when we are performing a physical examination, sometimes we may run out of time, and it is going to happen. Regardless, like how good you are, you will miss out on the time sometimes. If not in all 12 stations, probably in 4, 5, or 6 of them. So in order to make sure that you let the examiner know that how you're going to approach this station is to explain what you're doing. For example, as we were doing yesterday, how you start, how you introduce yourself. Now, when you start the physical examination, let the examiner know that what is your plan. For example, I'm doing a physical examination on the back of X and Y or Z, right? By physical examination, I'm focusing on 3 or 4 areas, or I'm focusing in these 4 areas. For example, I'm going to do an inspection, then I'm going to do palpation, then I'm going to do some special tests. I'm going to finish it with the neurological examination and summary. So it means that you know your plan, you have your structure. Let's say you did not make it to neurological examination. The beauty of this, to let the examiner know in advance that this is your plan and a structure, how you want to approach this station, is that you know how to do it. If you run out of time, the examiner knows that you said that you're going to do the neurological examination, but you didn't have time. So instead of giving you 0, he's going to give you 1 or 2. Not 5, but 1, 2 is always better than 0. Okay, so please mention what you're doing. So targeted physical finding, what you're doing, let the examiner know in advance. Red flags awareness, urgent pathology must be recognized early. So when you're doing these things, you need to be aware of the red flags. Clear explanation to the patient and concise closing summary. Always do a summary before you leave, okay? OSCE, so before touching the patient, always explain, explore appropriately, ask the patient to tell you what if pain increases. Okay, so for example, I'm gonna touch your shoulder. Is that okay with you? I have to let you know. This maneuver that I'm doing on your shoulder or performing on your shoulder might cause you a little bit of discomfort. So you're preparing your patient in advance, okay? And if it causes any pain, let me know. I'm gonna press against your shoulder, okay? It might be a little bit comfortable. Please let me know if it is painful, okay? So this is how, before you touch, you need to explain. Everything you do, you need to explain. If it is going to be uncomfortable for patient, or if it is going to be cold to touch, or it's going to be hot to touch, whatever. You have to let the examiner know, the patient know, okay? During an inspection, we are observing the mobility, the posture, the willingness to move, and the stress, okay? When we are observing everything, not only if the patient is having a back pain, focusing only on the back pain, but forget about the movement. No, we're focusing on the movement as well, okay? The way the patient is sitting, the way the posture of the patient is, or if the patient is in a comfortable position or not. During the exam, choose only test that answers the clinical question. Every single condition has a special test. When we say special test, it means that a specific test is designed for this condition. Or if it is not for this condition, it is used for this condition to rule out something very serious or something that's very similar to this condition. So it means you cannot pass as a station if you're not performing that physical examination, that the special test. The special test of that physical examination. For example, if you're having a patient with a back pain, if you're doing, let's say, for the back pain, you're something that has nothing to do that, like, for example, abdominal pain also has radiated pain. Let's say you're doing a chest pain, chest examination. It has nothing to do with the back pain, right? Unless it's upper back, aortic dissection, we can say that. But other than that, like, you're doing something that has no relation to the back pain. For example, checking the elbow, which has nothing to do with the back pain. So it means you shouldn't be wasting your time on doing the physical examination that has nothing to do with this condition. You need to be very focused and do those special tests that is designed specifically for this condition. For back pain, what do we do? Faber test, straight leg test, and tripod test, right? These are the things, or a femoral stretch test. These are the things that we are doing for the back pain. They are specific for all types of back pain. Other than that, doing shoulder test has nothing to do with that. I'm not going to waste my time doing that, okay? At the end, state whether the picture is mechanical, radicular, inflammatory, or dangerous. So at the end, when I did all this, my most likely finding based on the physical examination, my patient has mechanical back pain, whatever it is, unjustified. Why? Because the patient had paraspinal tenderness, this and that, okay? Now, the station map, your 6-part physical examination. These are the steps we need to take. Step 1 is setup, hygiene, consent, expose, ask the patient to report the pain. Number 2, look, general mobility, posture, scoliosis, scar, spasm, and distress. So for the look, again, remember we do 2 types of look. One is general inspection. We generally inspect the patient and report. Then we do a focal or a focused or a local inspection. For the local inspection, always we do SEADS, SEADS, swelling, erythema, edema, atrophy, deformity, scar, or skin changes. Okay? Then feel, midline tenderness, paraspinal tenderness, sacroiliac joint tenderness, point of maximal pain. So for different joints, it is different. For different location, it is different. But feel has to be done. But before we do it, we mentioned that the physical examination that I do is in 4 parts. I do an inspection, I do palpation, I do special tests, and I finish it with a neurological examination and summary. And then you start. Move, flexion, extension, side bending, no pain versus stiffness. So for this part, it is very easy, and the patient is not going to get confused if you do it yourself and ask the patient to copy it. For example, ask the patient to copy you, like stand straight. Can you bend forward like me? Can you extend backward, or can you lean backward like me? Or can you lean on the right side like me? Or can you lean on the left side like me? So instead of saying or asking the patient to do something which he has never done it, and it might be time consuming, just do it and ask the patient to copy you. Can you do this? You don't have to even say bend or flex or extend. Can you do this? Can you do that? Can you do this? Can you bend forward? And see how the patient movement is. It really helps you to find if the patient has any limitation, which we are going to talk, why we are doing it, and what is the benefit of asking these range of motion, because it helps us to find the right diagnosis. Function plus neuro. For example, in the range of motion, before I move to the function and neuro, for example, somebody who cannot move in any direction, not flexion, not extension, not lateral flexion. It is ankylosing spondylitis, right? The stiffness all the way. It will be stiff in any direction. So it helps me to know if my patient has ankylosing spondylitis. So function plus neuro. For the function and neuro, remember, when you do the neurology exam, so what are the part of the neurology exam that we do? We check for the motor, we check for the sensory, we check for the reflexes. So let's say you have done the inspection. Let's say you have done the palpation. Let's say you have done all the spatial tests. Now it's time to do neurological examination. Now I'm going to start performing my neurological examination. The neurological examination is in 3 parts. I would do or check for the sensory. Sorry, guys. What happened? Okay, somebody called me and caused this issue. Sorry, guys. It should share, right? What happened? Oh, she's calling you now? All right. So what I was saying. Neuro. Okay. So I was talking about neuro. For the neurological examination, you mentioned that this part had a neurological. Now I'm starting to perform my neurological examination. In neurological examination, I'm checking for the tone, I'm checking for the sensory, and I'm going to check for the reflexes. And you start with the tone, or you can start with the sensory. It's totally up to you. But as long as you cover these 3, you should be fine. So let's say your patient is lying down. So if the patient is lying down, it's always good to start with the sensory, then ask the patient to sit, do the reflexes. Then when the patient stands, then do the motor as well. Why? Because you can ask the patient to walk, give you a walk, which helps you with the tone as well, right? So walk is going to help you to see if the patient has tone. And you can always do it while the patient is lying down, just to make sure that the patient has enough tone to give you a walk test. Unless the patient is paralyzed or the patient has a stroke, other than that, it should be fine. Okay, so walk, heel, toe, power sensation, reflex, when indicated. A special test that we do is straight leg test, slam for the radicular pain, Faber for the sacroiliac joint tenderness, and Schober test for the ankylosing and spondylitis. So one line memory aid, explain. Explain and inspect, palpate, range of motion, gait and neuro, plus targeted special test. Always do the special test before neurological examination, because for any back pain, if you do everything except for the special test, you will definitely fail that station, because that station, the special test is heavily scored. So it means that is something that you need to do before you run out of time. If you lose the neurological, you might lose 5 marks, but if you lose the special test, you might lose 20 to 30 mark, and you don't want to lose that because for each special test, you have 5 mark out of 5. If it is 3, 15, right? So do the special test and then do the neurological examination and then do the summary. So start strong. Remember, the first impression is the most important. The first impression is the best. If you manage to impress the examiner as soon as you start, everything will go very smoothly. If you start weak, trust me, first of all, you're going to be all over the place. And trust me, the examiner is not going to be kind and nice as well. So try to start it very strong, okay? Set up a script. For example, I would like to examine your back. I think we did this yesterday, right? You introduce yourself, you confirm the patient name and ID, date of birth, and then you start to explain your role. I would like to examine your back and leg. I will explain each steps. Keep you covered as much as possible and stop if pain becomes too severe, okay? Or you can word it in your own way. This is an example. You shouldn't be like memorizing this. This is, I just try to make something to give an idea of like, what are the things that you need to cover? But you can word it even more beautifully than this. For example, my name is Dr. Muhammad. I'm one of the doctor in the ward today. I'm tasked to perform a physical examination on your back. I hope it's okay with you. By physical examination, I mean, I will take a look at your back. I will feel your back. I will touch your back to see what causes this back pain. I hope that's all right with you. And I might ask you, I might perform some maneuvers. I might ask you to help me with those maneuvers. Some of them might be uncomfortable, but I will try my best to make it as comfortable as possible. If you think that some of these maneuvers are not comfortable or causing you pain, please let me know and I will stop right away. So you can word it as nicely as you can. It is totally up to you. I just give you an idea. Hand hygiene and consent. Ask patient to stand if able. Always when you're asking the patient to stand up, again, just act that I'm here, I'm going to protect you and verbalize it. Not only act, you need to verbalize it and assure the patient that stand up. Are you able to stand? The patient will say, yes. Okay, can you stand up? I am just going to make sure that you're not going to fall because whoever you're asking to give you a walk test, like for example, walk on the toe or walk on the heel, he or she will lose balance, right? So always we have to protect regardless of if they have any issue with the balance because those walks are not easy to do. And just act, okay? Expose from the lower thoracic spine to the gluteal cleft as needed. Observe how the patient gets up before you start. Inspect the seats. Always inspect the seats. Remember that for the focus, always this should be on the top of your head. Seats, swelling, edema, atrophy, deformity, and scar or skin change. This is what I'm looking. You can add some of the stuff based on the location. For example, for the back, I'm checking for the contour, right? And then you move on to other stuff like swelling, edema, and so on and so forth. So, and always we look before we touch. Palpation, target the patient to localize maximal pain with one finger. When you're checking the spinous process, the midline, it is totally up to you to press with 2 fingers, or you can put 2 fingers, this one and this one, on the paraspinal muscles, and with this one, you can check the spinal process. With these 2, you're checking the paraspinal. But if you want to do it in an orderly fashion, first finish the spine itself, then go for the paraspinal. You can use like this, 3 fingers with your thumb, each side. But one of the most important thing when it comes to palpation is that when you're doing this, you not only ask the patient to let you know if there is any tenderness present, you need to look at the patient's face, the facial expression. What happens if you have pain, right? Your facial expression changes. Ouch. Not only you're making sound, your facial expression changes. In some cases, some people, they might not make any noise, but the facial expression changes. So it means if I'm checking someone's back, I need to take a look at the patient's face. I have to keep looking at his facial expression if there is any change. Not only I'm asking, I'm just trying to double check if the patient is having any facial expression change. And other than that, I think we covered everything. Midline tenderness, think about fracture. Let's say if you're checking for the tenderness in the spinous process, the midline, if there's a tenderness, there's a possibility of fracture, but or infection or malignancy. Other than that, if the paraspinal, it could be mechanical. Now, movement, function, and focus neurological examination. Range of motion, pain-limited mechanical back pain or stiffness in the inflammatory disease. Again, for flexion, extension, ladder bend, and rotation. These are the things that we ask the patient to copy. Copy me. Can you do this? Can you do this? Can you bend forward? Can you bend backward? And see if the patient has any limitation, report it. Remember, we are not only asking the patient to do that, we have to report it. Let's say I ask the patient, can you do this? The patient can't do it. Right or lateral bend is limited or restricted, or the patient cannot laterally flex on the right side. So you have to verbalize it. Even if the examiner is behind you, which in most cases they are going to be somewhere on your sides, that you can take a look at him, at the same time have a proper eye contact and report it. Even if he is at the back, just verbalize it loudly. For example, the patient flexion forward is limited or restricted. Please report it, okay? So flexion, pain-limited mechanical back pain or stiffness in the inflammatory. So if the patient has flexion issue, if the patient has stiffness, what do we think? Most likely this is going to be inflammation, either rheumatoid arthritis, either the ankylosing spondylitis, or anything that has anything to do with inflammation. So extension, facet loading can worsen with the spinal symptoms. Somebody that who gets worse while he is extending, spinal stenosis. Or lateral bending, asymmetry, spasm, focal restriction. A rotation, usually we don't do it. It is hard and it is uncomfortable for patient. As long as you do the flexion, extension, and lateral bend, you should be good, okay? Always state whether the motion reproduce the back pain, buttocks pain, or leg pain. Now, when the patient is saying that I have pain, thank you very much for mentioning it. Where? You have back pain, or it relates to the buttocks, or it is in your lower leg, okay? We don't just say, oh, this test is positive. The test is positive, but where is the pain? It could be at the back, it could be at the buttocks, it could be at the leg, okay? Pinpoint. Function, walk normally, heel walk, toe walk, sit to stand. These are the things that we ask the patient to do that, and I will explain every single one of them. Function matters because MCC expects assessment of the impact and return to the activity advice. Focus lower limb neurological. Again, when we do this, we explain that I am going to start my neurological examination right now. And in neurological examination, I'm going to focus on motor, I'm going to focus on sensory, and I'm going to focus on reflexes. I would like to start it with motor. I would like to start with reflexes. I would like to start with sensory. It's totally up to you. But usually we do the reflex at the end or before the tone. And we do the sensory first. Power, hip, knee, ankle, sensation to light touch, knee and ankle reflex. Document asymmetry, not only document, verbalize it, any And remember that any finding supposed to be compared with the other side. If you see any power weakness on the right side, compare it with the left side. And most of the time, they will say skip it. For example, the L4 is normal. L5 is normal on the right side. S1 is normal on the right side. So what about the left side? So when you say the L4 on the right side is normal, now I'm going to compare with left side, skip. As long as you mention it, the examiner will tell you skip. But if you don't, you lose mark. Because it is impossible to know if the patient has a normal tone or weaker tone if you're not comparing it to the other side, right? And same thing goes with the sensation. Same thing goes with the reflexes. Reflexes, you don't have to, but always good to compare it. High yield spatial test, choose by hypothesis, not by the habit. So use only the test that answers the question raised by the history and core exam. So again, do the test that is designed specifically for that condition. Straight leg test. A straight leg test, the patient is lying down on supine, knee is extended, raise the leg. I will show you how to properly do or position your hand and the patient's leg that you can get a proper test and also a proper result. So raise the leg and ask whether whether typical radiculopathy pain shoots below the knee. I will raise your leg slowly. Tell me if it reproduces leg pain. So this is how we ask the patient. Faber test, supine, figure of 4, stabilize pelvis and gently pass the flexed knee downward. I will show you how to do it. It's a little bit hard to understand it from writing or from reading, but if you do it once yourself, it is very easy. You will never forget it. Oski, I will place the leg in the figure of 4 position to check the hip and sacroiliac region. Cross leg, I will skip this one because it is not commonly done. Okay. Schober test, very specific for ankylosing spondylitis or any inflammatory back pain. If you're suspecting any inflammatory back pain, especially ankylosing spondylitis, please do the Schober test. This is very specific. So mark the lumbosacral junction and 10 centimeter above. I think I have to do it so that you can get it. I do have a picture. I think I shared it in your notes. You should be able to find it if you do check the back pain in NAC OSCE. You should be able to find the picture, how it's done, but I will do it here today. Measure the increase with the forward flexion. So I have to do it. Otherwise, it's going to be very hard to explain. Oski, I will measure lower back flexion using 2 skin markers. So you basically mark between 2 nevus, dimple of nevus. Yeah, between 2 dimple of nevus, you go 10 centimeter above, 5 centimeter below, and then ask the patient to bend forward as much as possible with knee fully extended. So if the patient bend and it reaches to 20, less than 20, it is positive. So it's for normal person, it's supposed to be more than 5%. But for somebody with ankylosing spondylitis, since they have a stiffness, they cannot bend forward very far. So it will be less than 20. So 5 plus 10, and that 5% that has to be added on after flexion, that will be less than 5%. I have to show you guys. It's a little bit tricky. So yeah, cauda iguana. So for the cauda iguana red flags finding that changes your exam and your plan, the patient would have urinary retention and incontinence. Please do not forget if you're taking history. If you forget this, then again, it will cost you a lot of mark. Saddle anesthesia, bilateral leg weakness, rapidly progressing this deficit, infection. In terms of infection, obviously everybody knows it: fever, chill, IV drug use, immunosuppression, severe focal tenderness, pain at rest with systemic illness, fracture, malignancy, trauma, or osteoporosis, steroid use, non-cancer weight loss, constant night pain, inflammatory pattern, usually morning stiffness, improve with the movement, alternating back pain, reduce chest, and lumbar expansion. Usually for the chest expansion, this is very special test for ankylosing spondylitis after shower test. I haven't seen many people doing it, but it doesn't mean they will not ask you. What happens, you ask the patient to inhale fully, exhale fully. You then measure the chest expansion and then ask the patient to take a deep breath in. If the changes is less than 2.5, it means it is ankylosing spondylitis, which is going to be restricted. But if it is more than 2.5, it is normal. More than 2.5 centimeter. Okay. Examiner phrase. Because of these findings, I would stop routine maneuvers, ensure patient safety, and arrange urgent assessment investigation. So these are the conditions that you stop doing the physical examination and you refer the patient to specialist. Close the station like a resident. So one thing that I always, for all of my IMGs, mention, that when you enter to the station, you are a doctor. Don't think that you're a student, okay? Deal with it like a professional doctor. Every single one of us have been practicing, except for some of us, like maybe most of us have been practicing for a very long time. We have seen patients on daily basis. So deal with it like a real physician, like a resident, not like a medical student. Don't be under a lot of stress. And I'm pretty sure you will be fine. If you have that self-confident and you always have the knowledge. Other than that, just work on your communication. Remember that English is not our first language. So nobody's perfect. My English is broken. I have a tech accent. I'm pretty sure everybody is having the same issue. So even the person who is an examiner, he probably have worse accent than you. So don't worry about that. As long as you make it clear, crystal clear, talk very clearly, and be professional, everything is going to be fine. So just deal with the station like a professional medical doctor, okay? That's the most important part. This is a patient with a, so how we can in 1 minute summary the whole station. And as I say, start it strong, finish it strong, okay? This is a patient with a back pain whose exam shows mechanical, radicular, inflammatory, fracture, this or that, or whatever. I found key positive finding. What did you find positive? Straight leg test, Faber test, this or that, whatever. And I did not find major red flag. Based on this, I would treat conservatively, or I would do investigation, or I would not continue the physical examination. I would like to refer my patient to a specialist because the patient might have malignancy positive, right? So summary, significance, plan. Thank the patient, help them to recover, recover, and I mean, do not leave if the patient is exposed, right? If you expose the chest or the back, cover it, then leave. So you cannot leave it just hanging the patient, leave the patient hanging like unexposed there, right? So thank the patient, be very respectful, thank the patient, thank the doctor, the examiner, and cover the patient again. And if you can help him to sit back or whatever, and then just leave, okay? And signal the examiner that the station is completed. Common pitfall, doing every special test, like doing every special test that has anything to do with the joint. which is not even related to the back. Just do the special one, which is very commonly tested for that specific condition that you're dealing with. Missing gait, always ask the patient with the back pain to give you a walk test. Forgetting the reflexes, ignoring modesty. See, it is not about knowledge. Be modest, be professional, be kind, be nice. No interpretation at the end. Like, what did you find? Right? What was your finding? What do you think it is? 10 seconds pre-entry checklist. Red flags first. Look before touching. Function plus neuro. If indicated, special test only if they answer the question. Close with a diagnose level plus plan. Best final line. That completes my examination. Thank you. I will now summarize my finding and next step. And thank you very much. Let's do some physical exam.